Good afternoon to one and all. I'm Dr. Amit Tabar, head of the surgical ICU and emergency at Fortis Raheja. We have with us Dr. Anand Utture, a consultant urologist working at TESIL Raheja Fortis Associate Hospital for the last 17 years. He specializes in minimally invasive surgeries and lasers in urology. Today, he's going to give us all the information that we need to know about the kidney stones and its management. So welcome, Dr. Anand Utture.
Thank you very much.
So without further delay, I will just come down to the questions. Sir, how common are the kidney stones really?
Kidney stones are extremely common. In about, if you say, there are 1 million new cases which are formed all over the world as far as the kidney stones are concerned. In cases of men, it is more common as 1 in 10 men and 1 in 35 women. In their lifetime, at one stage, they will definitely have stone at some stage in life. This common is the kidney stones.
Oh, wow. Is it really a new problem, or do you think in your practice that the incidence of stone is gradually increasing over the last few years?
Stone problem is very, very old. The first time the first stone incident was found at El Emra, that is in Egypt in one of the mummies, 4800 BC. That is approximately 6800 years ago. Our own surgeon Shushruta did the first perineal urethrotomy in case of urethral stone. So this problem is there for a very long time. Now, over a period of time, what has happened is the incidence has increased because the pickup rate is very easy. Because one of the modalities of treatment and what we use, investigation modality what we use is something called sonography, which is available in every villages now, and the penetration has been to smallest of possible hospitals. So the pickup rate of stone has increased. Of course, the various dietary incidents, dietary habits, etc., the change which has happened because of that is also a reason why the stone incidence is increasing.
Okay, there's quite some information. Sir, are all the stones the same when we talk about kidney stones, or are they different?
The commonest kind of kidney stone that what we see in India, calcium oxalate, dihydrate, calcium oxalate, monohydrate, uric acid, and in case of infection, these are cystine stones. These are the common things that what we see in India. All over the world, there are other types of stones which are xanthine, hypoxanthine, cystine, etc. In case of infection, we get a very specific type of stone which is called as stowite. So in India, what we come across is mainly the calcium, uric acid, infection, and a mixed type of stones.
Okay. So what is really the causes of this stone formation, or what is the etiology, you would say?
The common etiology that what we see is the vitamin A deficiency. If there is infection in the kidney, ureter, bladder system, that infection can lead to stasis of urine. When the urine gets collected in the urinary bladder because of prostate enlargement or maybe PU junction obstruction, the stone formation rates are very, very high. At the same time, various disorders like hyperparathyroidism, where the calcium metabolism is at stake. And this calcium metabolism, the calcium which is increased in the serum or the blood, goes to kidney, and that calcium gets filtered and deposited in the kidney, and it can form kidney stones. As well as there is something called as the gout, which is quite a common condition where the small joints of the body are involved. These are we call it as a gouty arthritis. In this, the uric acid levels are very, very high. This uric acid levels which become high forms a nidus, and on that the stone can get formed, and a patient can have a common uric acid stone, or it can have a mixed stone which is built up onto this uric acid. So this is what the usual etiology for stone formation is.
Now that you have told about this, sir, how are the stones really formed, or would you like to tell us something about the pathophysiology of stone formation in the body?
The main reason for having these stones is something called as dehydration. So the body requires water, and if you don't have enough amount of water that what you drink, there is a formation of stones. Now just imagine, say, 5 teaspoonful of salt. You put in a glass of water. The entire salt will get deposited and will remain at the bottom of the glass. But the same water, if you push it into, say, a bucket full of water, everything gets dissolved. So this is what the mechanism is. So as there is more water, all the solutes or all the calcium salts, they get uh, dissolved in this urine, dissolved in the water. It goes to the kidney filters, and the whole salts are filtered out instead of forming stones. But of course, this is not the only reason. Now, if you see some stone belts, that's what we call it as an interior of say Maharashtra, say Solapur, or say Rajasthan, Kutch. Here, the salt calcium levels are so high that even if you drink a lot of water, because of high contents of calcium, there is a possibility of stone formation. Now, are these the only reason why stone formation is there? No. Then there is something called as stone matrix therapy. Then there is something called as multifactorial inheritance. Now, what I mean by multifactorial inheritance is it is not one cause that can cause these kind of stones. Suppose there is a family of say four. They're staying in a house. One family member will have a stone, but the rest of the whole family member may not have stones. They're eating same food, they're drinking same water. Again, brothers and sisters, same genetic predisposition. Brother may have stone, sister may not have stone. Again, one body, two kidneys. Patient can have stone once or repeatedly in right or left kidney. The other side of the kidney may not show any stones. So this is not dependent upon one factor. Of course, there are a lot of contributive factors. If we take care of these contributive factors, the incidence of stone formation can be reduced and can be controlled. But there is no one factor that can lead to this kind of stone formation.
Right, sir. Right, sir. So when do you suspect that your patient has stones, or what are the common symptoms of that a person has kidney stones?
The commonest symptom with which the patient presents to you is usually pain. Now, this pain is very typically called as a renal colic. It starts from the back and goes in front. That is, it starts at the back region where the rib is and starts going towards the urethra or the penis. This is, we call it as a radiating pain, loin to groin pain, very classical of stone formation. But if the stone is in the mid-ureter or bladder, this classical symptom may not be there. The patient can present with hematuria, that is bleeding in urine. He can have fever with chills because of infection because of the stone. He can have acute renal failure, chronic renal failure because of obstruction which is caused because of the stones. So these are usually the symptoms with which the patient presents to us.
Right, sir. So what are the investigations that would follow, sir? How would you arrive at a definitive diagnosis? What are the investigations that you do, the commonest investigations?
The commonest investigation that what we do and what we should first do is should do a sonography. Now, this sonography is called as a sonography KUB, kidney ureter bladder. This gives us where the stone is, how many stones are there, and whether there is any obstruction because there is a pressure on the kidney. So this gives us a direction of how we should proceed in doing investigation for the stone patients. But of course, sonography need not pick up or may not pick up all the stones. So we have the best golden standard modality of investigation, and that is CT scan KUB. That's the CT scan of kidney ureter bladder region. This is 100% sure shot modality of identifying stone. Once we know that the stone formation is there, then we do regular routine investigation like CBC. We do BU and creatinine to see the kidney function. We do urine routine and microscopy, and we do culture test to see whether there is any infection. Along with that, we do calcium, uric acid, phosphorus levels of the blood, because these are the conditions which can lead to again and again stone formation. Along with that, we do a test which is called as serum parathyroid hormone. This, if it is high, the calcium contents of the blood is very, very high, and because of that, very commonly stones are formed. So these are the investigations usually we do when any stone patient comes to us.
Okay, sir. So you talked about stone formation, you talked about recurrence. So what are the general measures that you would advise our audience to take to avoid kidney stone formation, sir? Is it possible to avoid kidney stones in the general population?
We already talked about the multifactorial inheritance, but there are a lot of things that one can follow in your day-to-day activity. Like you should have water, which is at least 2.5 to 3 liters. Now, how will you know that whether you're having the water which is adequate? Whenever you pass urine, the color of the urine should look pale yellow or white. Now, this water, what you're taking 2.5 to 3 liters, should not be that you're taking 1 liter in the morning, 1 liter in the afternoon, and 1 liter at night. It should be 1 glass of water every 1 to 2 hours, so that the body is hydrated. Whatever the salts which are there remain inside the water, and whenever you pass urine, the urine is flushed out. Second thing is milk and milk products should not be more than 1 glass a day. Mainly red meat is the one which causes the uric acid stones. So if the levels of uric acid are controlled by avoiding red meat or decreasing the content of red meat in your body, this is the way we can avoid stone formation. The maximum that what you can have every day is 240 grams a day. That too, you should not have it every day. This leads to uric acid stone formation.
That was very vital, sir, because we in our day-to-day life really forget to drink water. That was very important thing that you said, that you need to take water 1 to 2 glasses every 1 to 2 hours. That was a very vital information you shared. So what would be are there any associated food restrictions also? You mentioned about red meat. Anything else, sir? Anything that else matters in this, contributes towards this kidney stone formation? The food.
You asked me a question whether during today's era, whether the number of stone patients are increased. They're definitely increased, and that's because of the dietary habits. The dietary habits, when you have a lot of coffee, tea, you have lots of chocolates, or you have seed containing fruits as well as vegetables. These are the common causes which can lead to this kind of stone formation. Along with that, what you should understand is that there's a very common thing which is always asked to us, that whether I am on calcium supplement, whether I should continue taking the calcium supplementation. Now, if you are forming stones, and if you are in an age group which is something beyond your menopause, or if you are old, then the most important thing that what you need to understand and take care is your bone health. If by physician's advice, if you are taking calcium for prevention of osteoporosis, that should be continued. But at the same time, you should keep on doing your serum calcium levels in the body to see that the stone formation which are there, that is not because of high levels of calcium. Of course, the majority of stone formed in a urological term, we call it as a normocalcemic hypercalciuria. That is, the calcium level in the blood can be normal, but at the same time, there is a possibility of stone filtration level in the kidney become more, and because of that, there is a possibility of stone formation. So these are the things that what we try to avoid to prevent this kind of stone formation.
Right, sir. So can this be managed medically or only surgically? What are the medicines that can help our kidney patients, patients with kidney stones, sir?
The role of medical management, that depends upon what kind of stone, what you are looking at. If it's a calcium oxalate, monohydrate, calcium oxalate, dihydrate, these kind of metabolic stones which are there, then usually we give something called as the potassium citrate solutions. This potassium citrate combined with calcium forms a calcium citrate, which is dissolvable in your urine, and that can be flushed off. At the same time, the other modalities that what we can do, as far as this thing is concerned, is in cases of uric acid stones. We give something called as xyluric acid, which is a very common drug which is given for gouty arthritis. This reduces the uric acid levels in the body. As the uric acid levels go down, the formation of uric acid stone also becomes less. The third part in which we talk about the medical line of treatment is when the patient comes to us with acute pain. Now, whenever this patient comes to us with an acute pain, what you really need to do is you need to be injection the tablets to decrease the pain. That's what is the first important thing that what you have to see. The patient may present with vomiting, patient may have a lot of nausea. So the treatment should be to cover his nausea and vomiting so that he can start his day-to-day activity very simply. And along with that, there is something called as a diuretic therapy for flushing of the stone. Now, many times what happens is when you realize that you got a stone, you start drinking a lot of water. Now, when you start drinking a lot of water, this stone, if it is not flushed out, if it's a large stone which has got stuck, the pressure on the kidneys increase, and because of that, there could be a problem in the kidneys. There can be a fornical rupture, that is a rupture of the kidney, or you may get pain, which is very, very excruciating. So the entire thing depends upon what size of the stone is there and where is the stone, and according to that, you can have a medical management for this particular kind of stones. The main medical stone comes into play only when we clear the stone and we do various activities of what we talked about to prevent a further episode of stone. That's what you can do with medical line of treatment.
Yeah, the pain is really, really severe. I mean, I can vouch for it from my personal experience too. So, but if the medical management does not help or it's not help, what are the different types of surgeries that can be performed on these patients to allay them from the kidney stones problem?
Surgeries about stones are mainly divided into 3 parts. One is an open surgery, which is an age-old method where we take incisions on the body, go inside, open the kidney, take out the stone, suture back the kidney, suture back the wound. That is the first treatment option. That's what we call the open surgery. Nowadays, for any kind of stone, we don't do this open surgery. Second option is laparoscopy or robotics. Laparoscopic robotics, same indication. If you can do it with open surgery, laparoscopy and with robotics can do the surgery. Now, what we do in today's our practice, we do something called as ESWL and minimally invasive therapy in the form of endoscopy with associated laser treatment for this particular stone, where the injury to the body which occurs is at minimum.
Okay. So you talked about these various surgical modalities, but which would you prefer, or which would you recommend for which patient? How do you decide on that? Which surgical modality would you prefer, sir?
First thing, we have to understand this fact that stone formation and what is going to be the recurrence rate. 7% of every patient who forms stone will reform stone every year. So at the end of 5 years, you can say that 50% of the patient having stone once in life may present again with stone formation. Second, if the stone is less than 4 millimeter, okay, 70% of the chance that it can come on its own. But when it becomes 4 millimeter above, the chance of spontaneous expulsion of stone becomes about 10%. So whenever we are going to offer any kind of treatment to the patient, the treatment should be minimally invasive or non-invasive. Now, what I mean by minimally invasive or non-invasive, the treatment that what we offer to the patient should not cause any kind of harm to the body in the form of incision or scar or a hole in the kidney, etc. So that is the reason my preferred, and all over world in all advanced centers where kidney stones are treated, the preferred modality of treatment is nowadays ESWL and endoscopic management with laser for the stones.
Okay. Sir, but I hear a lot about ESWL. Can you tell the audience something more about it? What is really ESWL?
ESWL is extracorporeal shockwave lithotripsy. Now, this was introduced in the world in 1982 by Chaucer. And from there, we call it as the golden era for management of kidney stones. Because people used to look at kidney stones and they used to always do the cut operation and take the stone out. Nobody ever believed that minimally invasive therapy, any kind of other modality of treatment would be possible. But once this came into play, patients started getting treatment with this ESWL technique, extracorporeal shockwave lithotripsy. So in this, what happens is there is a machine on which the patient goes and sleeps. In this, there are electrohydraulic or electromagnetic waves which are generated. These electrohydraulic and electromagnetic waves which are generated go and hit the stone, break the stone, make it into powder form, and then these stone fragments which are formed are cleared through the regular urine. This technique is called as ESWL, extracorporeal shockwave lithotripsy.
Okay, sir. At the beginning, you mentioned that there are different kinds of stone. Would this technique help to break or relieve all the stones?
If ESWL works for any kind of and every kind of stone, it is the easiest possible modality of treatment, and everybody would have continued with the same. Now, unfortunately, what happened was when the stone is a bit hard stone. Now, whenever you do the CT scan, we always ask for a hardness of the stone, which comes in the form of Hounsfield unit of the stone. Now, with this Hounsfield unit of the stone, we come to know that whether the stone is hard or not hard. If the Hounsfield unit is less than 950, there is a possibility that the stone can break with ESWL. But if it is more than 950, the stone breakage by ESWL is practically not there. Another thing is, it depends upon where exactly the stone is located. If the stone is located in the lower calyx, that is the lowermost part of the kidney, even if the stone is broken, these fragments don't get cleared off. So the clearance rate is approximately 46% in case of lower calyceal stone. So if you see the number of things, number of patients which are coming with kidney stones, if we have such a big number of recurrence rate where the patient had to undergo lithotripsy treatment again and again, or if the stone is very hard, the stone just doesn't break at all, we have other modalities of treatment in the form of endoscopy with lasers, which should be advocated. So ESWL, coming to your question, ESWL doesn't break or doesn't clear all the stones.
Okay. So you talked about this minimally invasive endoscopic management. Can you enlighten us more of the different types of endoscopic surgeries that are available in today's time?
Endoscopic surgeries, what we offer depends upon where exactly the stone is located. If the stone is located in the kidney, we have something called as PCNL, where we make a small hole in the kidney, go inside, do the laser technique, and clear the stones. If the same stone is in the ureter, a ureter is a tube which connects the kidney to the bladder. Means the urine gets formed in the kidney, and through this ureter, it comes out into the urinary bladder, where it gets collected, and from there it comes out. If the stone comes and gets stuck into the ureter, which is the commonest portion for the stone to get stuck, because this is the narrowest possible portion in the kidney ureter bladder system. If the stone is stuck in that area, we do something called as ureteroscopy with laser technique. If the stone comes down, or if there is a prostate enlargement because of which there is a secondary stone which is formed in the bladder, then these big stones are managed by doing something called as cystolithotripsy with lasers. That is, we enter inside the bladder through the urethra, that is from where you pass urine, go inside, look at the stone, break the stone with lasers, and suck it out. The most advanced technique among all these things, which we routinely and regularly using in our practice today, is something called as flexible ureteroscopy or RIRS. It is the commonest, best, and most advanced technique in management of kidney stones, which is absolutely minimally invasive to the patient, where there is no cut, no stitch on the body, and you can enter into any part of the kidney. How many are the number of the stones? Anything and everything can be broken with the help of this technique, which is called as flexible ureteroscopy with lasers.
Oh. So can we come to each of these? So can you elaborate something about ureteroscopy, sir? What do you mean by
Ureteroscopy
the whole scope
yes.
of it?
Ureteroscopy is a small scope, and these scopes enter inside our kidney, enter inside our urethra from where we pass urine into the bladder, and from there it enters the ureter. In the ureter, wherever the stone is, we reach the stone with this ureteroscope, and then with lasers, we break the stone and clear the stone. That is ureteroscopy.
Okay. Then what are the advantages with PCNL? When would you opt for PCNL? And what is its full form really?
The ureteroscope cannot reach the kidney. So whenever the stone is in the kidney, what we need to do is we need to reach the kidney. So to reach the kidney, what we do is we make a small hole from the back, go inside the kidney by making this hole dilated, enter inside with again a small scope, and through the scope we introduce laser inside the stone to break the stones. When the stones are broken, all these small piecemeal are picked up through the small hole which is made, which is connecting the kidney to the skin, and we take out all these stone particles piecemeal. That is what is called as PCNL. Now there is another advance than what we have through which we do the procedure, and that's called mini perc or micro perc. Depending upon the small hole that is made inside the kidney, this is differentiated into smaller and smaller scopes, and those smaller scopes are called as either a PCNL or a perc, mini perc, which is a smaller scope, and micro perc or a needle perc, which is much smaller, where the entry point of the kidney becomes smaller and smaller. So that is PCNL.
Oh, that was interesting. And can you tell our audience something about cystolithotripsy that you mentioned, especially when it comes to management of bladder stones?
Bladder stone is located in the lowermost part of the abdomen, and we directly enter through it by making a small hole from the skin into the bladder, or we use the urethra to go inside and enter into the bladder. It's a fairly simple operation where patient remains in the hospital for about 24 hours. We break the stone, however big the stone is, with the help of laser, and we suck it out, all the fragments through suction, which is applied onto the scopes, and clear. So cystolithotripsy means cysto is a bladder, litho is a stone, and tripsy is breaking the stone. So a technique which is used in endoscopy to break the bladder stone is called as cystolithotripsy.
Okay, and you mentioned about the latest technique being the RIRS and laser. Can you tell us something about it for our audience benefit?
Flexible ureteroscopy and RIRS. This is the most advanced technique today with which stones are cleared all over the world, whichever part of the developed or developing country that what you are in. Wherever I'm operating in laser centers, this is one of the operations which I do very, very frequently. The success rates are close to 100%. Any stone which is large, small, in whichever part of the kidney, we can enter into the kidney and we can take it out. Now, when we talk about this flexible scope, it looks similar to something called a gastroscope. Gastroscope is, everybody has seen this, how this gastroscope looks. That is, which is introduced to the mouth, into the stomach, and you do whatever is there in the stomach. So similarly, it's a very slender and smaller caliper scope, which is introduced through the urethra. Urethra means the opening through which we pass urine. From there, it goes up into the urethra, from bladder to ureter to kidney. And in the kidney, once it enters, it has got a small pulley. With adjustment of pulley, we can enter into any part of the kidney. But as you know, the kidney has got three parts: upper, middle, and lower calyces. These are anterior and posterior divisions, and there can be multiple subdivisions to these kind of calyces. So stone can be any part in this 6 to 15 different aspects of kidney, and each and every part we can enter inside, break the stone with lasers, put a stent across, and come out. The advantage of this procedure is that there is not a single cut or stitch on the body. That is the reason the acceptance rate by all patients for this particular procedure is very, very high. And technically, we have achieved this to give as close as, or you can say almost every patient, complete stone-free rate. This is a very good technique which is used for patients who are working on ship or airline industry, pilots, or pre-employment examination, where smallest of possible stone, if they have it, they cannot completely be fit enough to join the job. So these are the specific patients which come to us, where we have something called as a pickup as well as lasers, where we enter inside the kidney, clear the stone completely, and give 100% clearance. So today I feel that this particular procedure is what is the best possible technique available for stone clearance today, and this is what is going to be the future in managing stone and stone related problems in kidney stone disorders.
I really see that flexible uroscopy has revolutionized the management of stones. Sir, are there any more advantages that you would like to mention about flexible ureteroscopy?
It's a simple technique, not very expensive, is available today in all different parts of even taluka places in big hospitals. Only thing is the learning curve for this particular procedure is quite steep. It takes a lot of time to get acclimatized to this technique. But once you know the technique, urologists like me, we will always have this kind of treatment modality to offer to the patient. It's a simple technique, not very expensive. There is not a single cut or stitch on the body. Patient remains in the hospital for 24 hours. Within 24 hours, patient can go home. The chances of bleeding are very, very less. Chances of infection are very, very less. And patient can join back work within 48 hours of time. So these are the great advantages of flexible ureteroscopy or RIRS.
That's really fantastic. And so in these days of minimally invasive and flexible ureteroscopy, where do you position open surgeries, or for that matter, laparoscopy? Do you see any future in there?
Open operations, laparoscopic operations, or for that matter, even robotic operations for stones are limited today only if there is some primary cause in the kidney ureter bladder system which requires some kind of a treatment or reparative procedure. Something like, say, kidney opening into the ureter, that junction we call it as a PU junction obstruction. Now, this PU junction obstruction is there in small children, and secondarily, if the urine remains in the bladder, in the kidney, and that's where the stones are formed, then you can advocate either open operation, laparoscopy, or robotic surgery to do the open operation to repair that particular part of the kidney ureter bladder system and take the stone out. In my practice, we have achieved, and whatever we are doing, the laser treatment for stones, last about 8 to 10 years, we have not operated any patient with any kind of open operation for stone. Whatever is the stone, wherever is the stone, we always deal it with minimally invasive therapy and doing it with lasers so that we can clear the stone.
That's really a great news. Sir, are there any advantages of endoscopy with laser? Any other advantages for endoscopy with laser?
Endoscopic lasers, if you compare this with, again, laparoscopy, open operation, first thing is it is cheaply available, widely available. Admission time, antibiotic time, other medication time is very short because the stay in endoscopic procedure is not more than 48 hours. Open operation, it can be 6 to 7 days. Plus, there are no stitch and no cut on the body so that the patient doesn't have infection or a lot of pain in the particular site where there can be where we are operated. Patient can go back to work in no time. And one of the things that what I mentioned to you about is that whenever you're doing any kind of surgery, why a minimally invasive therapy? Because these are the patients which can again and again form stones. And if you're going to cut them and again, there's going to be tissue damage. The patient is going to be very scared of this operation and surgery, and many times they don't just follow up. And these stones can lead to renal failures, which can land the patient into going in for dialysis. So if we make the treatment option very simple, not so painful, easily available, and cheap, I'm sure that everybody would like to go for this kind of operation technique which are available, where you can very well treat the patient in 1 or 2 days time and clear them of stones.
That was a loads of information you had, sir, to share, and thanks a million for it. Any last take-home message that you would like to give to our audience to sum it all up?
What I would like to say is that all stones require treatment. Now, this treatment need not be surgery. It can be medical management. It can just be a follow-up, so that to see that the patient don't cause a harm to your body. So the treatment is either medical liner treatment or surgical liner treatment, depending upon what is the size of the stone, whether it has got any complications in the form of bleeding in urine, pressure on the kidney, or constant pain. So any stone that is there in the body requires treatment. ESWL and minimally invasive therapy along with lasers can take care of any possible stone in the body. We don't require to do any open operation, laparoscopy, or robotics. Over a period of time, the lasers are going to be stronger, the endoscopes are going to be more and more slender. So the minimally invasive part of this particular technique is going to be very well established. And fourth thing is, kidney stone is there with us to stay. So whenever you have kidney stones, to prevent further complications, and if they are small, to do a smaller procedure and minimally invasive procedure, what we really need to do is routinely, regularly follow up your urologist or your physician with sonography every 6 monthly and urine test to see whether there is a possibility of stone formation.
Thank you so much, Dr. Anand Utture. It was an extremely informative session where we traveled right from the history to its etiological factor to the causative factors, and we had a lot to learn about this minimally invasive and the various surgical modalities that have come into it. I would like to thank you for the time and this opportunity, and I'm sure my audience would benefit a lot from this information and be more positive towards management and proactive towards the management of kidney stones going forward. Thank you so much.
Thank you very much.
Thank you.